Thank you. Thank you, Gabrielle. And thank you all. It's a pleasure to be here this morning. So I'm Peter Ward. I'm a staff psychologist at Homebase. I do a number of things at Homebase in the ICP program and also the outpatient program, but I co-lead our SOAR outpatient addictions program, which I will discuss in my presentation. I don't have any disclosures to discuss or slides to show them, so I'm going to skip that. But today, what I want to do is talk about a couple things: our dual recovery supplement to our intensive program at Homebase for addictions and substance use disorders, and also our SOAR outpatient IOP program. But before I do that, before we get into slides, one thing I'd like to start to do to maybe make this a little bit interactive is to have you all consider, if you were seeking substance use treatment, how you might go about doing that and what you might be facing as someone coping with that. I bring this up because it's very common in the world of substance use treatment and addictions and mental health to kind of feel isolated or feel siloed. I think in healthcare, one thing we do for our own kind of organizational purposes is the following. We say there's healthcare, and then within healthcare, there's mental health. And then within mental health, there are specialties like PTSD and addiction and so forth, right? We do that because that's the way we organize things. However, from a patient perspective, right, some folks know like that is almost a signal that, they've been kind of siloed into like, not only are they in the mental health category, but within that, they are in the addictions category. And sometimes that can be in kind of unintended signal to the patient. There are two things explicitly that we try to do with our programming at Homebase to address that. I would say in our dual recovery supplement to the ICP, to folks like that might feel siloed or might feel isolated or looking for a place to go, we want to provide them that space within the intensive program. That's something we work hard to do. In the SOAR program, one thing we try to do is provide them a community where they feel welcome. I'll speak to how we do that shortly, but I just wanted to start with that to kind of put yourself in the shoes of a person approaching this kind of care, because I think there is a little bit of a difference sometimes when we consider this category. Okay, so this is an overview of our ICP program. Thank goodness Laura already gave you an overview. This is just another one, and I'm not going to go over all the boxes, but I just wanted to show you kind of the organization or the way that we account for substance use care within our intensive program. So there's the dual recovery or DR supplement to the program that I will speak about at length. So I'm going to kind of skip that right now. But then we also provide, when people come into the intensive program, we kind of have this scramble on our team to provide consults during the first few days to make sure that if people are sort of maybe not pre-assessed or pre-screened for substance use need, if substance use need comes up in their intake eval on the first day, we try to do everything we can to provide as many consults. Realistically, they might see a provider 2 or 3, maybe up to 4 times while they're in the 2-week program, if availability is there. So that's what a sub-consult is. We also provide education in our family programming on both the Thursday and Friday. It's happening today, starting today and going. We provide 2 education groups dedicated to substance use disorders for supports of our program participants. So that's sort of an overview. I'll get to DR in a minute. So dual recovery. So the story of dual recovery is kind of an interesting one. So if you know about the ICP program, right? So the ICP program has long provided excellent PTSD and TBI care for the folks who go through the door. The great irony, I think, of the ICP for many years was that folks would complete the program and maybe they had a comorbidity with substance use. And they might have said, wow, I really made a lot of progress in my PTSD, but in all those groups and individual therapy, I didn't really get a dedicated space to talk about my substance use disorder. So we tried to remedy that by creating the supplement to the ICP in dual recovery. So what we did was we have emphasized more kind of attention in the screening component of the ICP so that folks who have in their medical record kind of a history of substance use disorder are sort of pre-identified. We give them the option to participate in the dual recovery supplement. We actually, the providers such as myself will call them and sometimes offer them a 30-minute pre-education session to get them oriented to what we plan to do while they're here, because we have a lot to do in 2 weeks usually. And so there's sort of a screening component before they even get here. Once they're here, we implement the program, which is 6 sessions of what's called the COPE protocol, which is kind of a hybrid of an exposure component and also a traditional kind of substance use recovery, relapse prevention component. our framework. So that's what they're doing individually in the supplement while they're there with a dedicated substance use trained provider. We also have nurse practitioners who have an addiction certification. They have 2 sessions with them while they're here in the intensive program. So somehow we make this work with appointments. I never know how we do that. The other thing we do is we have great peer support in our VOCs and other folks, and we actually have some of our peer folks at Homebase themselves identify as in recovery, which is a great strength because they can be a nice liaison when people are finished with the ICP to keep up with them on the phone and meet up with them at certain follow-up time points up to the 1-year mark. Okay, so in terms of how dual recovery works, once a person is in the ICP, they're identified for dual recovery, they meet with a provider. So again, to take a step back, what's interesting to me about DR as a provider is that some folks will come in, they already have a goal. They say, you know, I've quit drinking or using a particular substance and I want to stay that way. I want to maintain my abstinence. Some people are struggling to meet that goal and they know that. And some people don't even necessarily agree that they have a substance use goal, but maybe people in their family have discussed it with them, or their boss or someone in their unit, you know, has discussed that there might be a substance use need. And so they meet me on the first session. They say, I don't even know if I have a substance use issue, which is where the motivational interview might come in. Wherever people are, we meet them on the first day. And the challenge is what I, usually say to someone is we have 2 weeks and next Friday you will go home. I hope that you go home with a plan. I'm going to help you with that plan starting today. So we usually set a goal on the first day of dual recovery. It's either a harm reduction or an abstinence goal. We have no skin in that game. We just want people to make a change goal. I have no influence over the type of goal a person makes as long as we can dedicate our time to it and it seems realistic for them to implement it when they go home. That's my criteria for a goal in dual recovery. And that's what we try to do with folks because we want to capture as many people as we can and help as many people as we can. We don't want our criteria to be a limitation to what they're doing. We want to take wherever they are and go with it. Because again, we have 2 weeks and we want to make a lot of change. So in this dedicated space, that's what we're trying to do. One way of doing that is the coping plan. So I'll sort of give it to you session by session right now. So there's 6 sessions. Ideally, sometimes we do it in 4 sessions if there's scheduling things going on, but we usually have 6 sessions. So we do an eval, an intake, we give them feedback. So for example, that feedback will do like a formalized substance use assessment and tell them where on the substance use disorder continuum, if they assess for that, they are. So like mild, moderate, severe, for example, in terms of like alcohol use disorder or cannabis use disorder, et cetera. Keep in mind, we also have folks that participate in dual recovery for what we might call like behavioral addictions. So pornography, gambling, video games, internet, et cetera, compulsive sort of behavior that you might be called colloquially like behavioral addiction. We apply the same protocol to folks like that. So, and all these sessions would apply similarly, maybe with a little bit of tailoring if there's a behavioral component. But so we do an eval. We begin what's called the coping plan, which is what it's literally kind of a one-piece a paper that they take home. I always tell them they can like put it on the refrigerator if they want and look at it. It summarizes what they do in the program. And one thing that I say to folks on day 1 is that I don't want to treat substance user. I want to treat you. And I want the goals to be specific to your needs. So we really work hard on that. I mean, every person that comes in the door, we want to make sure what they're doing is specific to their life and not some generic person in some sort of treatment manual or whatever that is the picture of someone with alcohol use or cannabis use disorder, et cetera. We want them to be specific, the goals to be specific to their experience because in the end, that's what they're going to be going home with. And that's what's going to go on their fridge in their home. So we want that to be kind of our focus. So in terms of topics of sessions, we work on cravings and the idea, I would say if we have any agenda in terms of like a focus or a modality in treatment, it's just that I tell people we want them to know what's under the hood in terms of what's in their brain. We focus on science and behavior of habit and how they can use their own knowledge of the human brain to cope with what they're challenged with their addiction or behavioral component. So we talk about risk. There's a session dedicated to that. There's a session dedicated to social support, refusal skills. There's a session dedicated to the intersection of emotion or coping and substance use. I would say that one thing I want to highlight about that is that sometimes one of these sessions might be really relevant to a person. I might spend more than a session on that if we identify that in the first day. So the tailoring goes very deep, I would say. So that's dual recovery. And again, I would say in summary, what we do with dual recovery is try to provide a dedicated space while a person's in the intensive program and a plan for when they go back, when they're finished, because it's a 2-week program. So we understand it's not their whole life, but we want to really make a dent in what's going on with their substance use issues. Okay, so in our outpatient clinic, we do a number of things to support folks coping with substance use disorders. The highest level of care is the SOAR program, which I'll talk about at length, but we also provide individual therapy. So providers that are skilled in substance use treatment, we might refer people to them. Medication management, we have a couple of providers that are addiction medicine providers. And the groups, the weekly group therapy groups, there's the recovery group, which has a harm reduction focus, and then there's the abstinence-based recovery group, which, as the name entitles, is for folks that are maintaining their abstinence on a particular substance or behavior. There's also a CRAFT. CRAFT is an acronym for sort of an educational family component group for supporting family members of people who are coping with substance use disorders. So there's a number of different options people have in our outpatient programming to support substance use disorders. So SOAR. SOAR is, when I use that example at the beginning, SOAR is near and dear to me. I say to people in SOAR that they're joining a community. We work very hard to facilitate that community because often, again, in substance use disorders, people come from a place of being isolated or feeling alone, and that's not a good place to be. The way that we facilitate community is a few different ways. SOAR is a group. It meets 3 times a week for about 90 minutes. The way there's a content component to the group, so either we're presenting a skill or an educational topic. An educational topic doesn't have to be SUD-specific. We do relapse prevention skills and things like that, but we also do a session on sleep, 2 sessions on coping with anxiety. We do a session on the intersection of military culture and substance use, and all sorts of other topics that we feel like are specific to our population. And we also work on skills from a number of evidence-based modalities like DBT, CBT, ACT, et cetera. Each person in SOAR has a dedicated clinician, such as me or someone else on my team, as their point of contact. We have a meeting at the beginning, middle, and end of treatment, as well as ad hoc support whenever they need it. But I would say the community kind of component of SOAR comes out in a few ways. First of all, we have a harm reduction kind of policy, meaning that I always say everybody picks each other up. So right now, actually in SOAR, we have a couple folks coping with alcohol. We have one person coping with cannabis use, one person coping with stimulants, and one person in there for pornography use. So that's our community right now, okay? And everybody's picking each other up. That's what I say to people before they get there. I tell them if they want to be in SOAR, that one of the only criteria is that you pick the other people up and you, even if you don't understand or agree with another person's approach. So let's say we have someone abstaining from alcohol and someone cutting down on alcohol. They're essentially sitting right next to each other in the virtual group. And during our check-in component of group, they're supporting one another. And so that's what we do in SOAR. We pick each other up. Because we have harm reduction component, people are cutting down. So people will come in during our check-in space and say, I had some recurrences of use over the weekend, and we'll just talk about it. And that's how we deal with it in SOAR. We try to move forward, and we don't criminalize it or villainize it, or we don't even really, give a lot of attention to it, because that sort of tends to reinforce stigma about, a recurrence of use is a failure or something like that. We just try to learn from it, basically. And we have people support folks. This is all done within our mental, so it's not a siloed, this is our addiction sort of place. It's in our mental health clinic. They get referrals through a normal intake, and everybody walks through the same door and walks out the same door. So that is the SOAR program in a quick nutshell. Some of the benefits, just briefly, that are sort of supported by the research. The COPE protocol has been shown effective as being kind of a specific protocol to address comorbidities when folks are coping with both PTSD and addictions. The folks that develop COPE have a number of studies that kind of support their efficacy in different ways, as shown on the slide. Similarly, with TBI, a tailored approach tends to be more effective for obvious reasons. And so COPE is an example of that. Folks in TBI recovery and substance use recovery are more likely to benefit from something that specifically accounts for their experience, again, as opposed to blanket substance use recovery person. Okay, so those are kind of my summary comments about both the dual recovery supplement and the ICP and the SOAR program. But really, if you came out of this talk with any kind of one-liner or thing to remember, I want you to know that we work hard to provide a space for folks And we also work hard to provide a community. And I would say that, you know, honestly, we have all sorts of evidence-based things we do, but if we didn't do that first, then these interventions wouldn't be worthwhile. So I'm proud to be a part of both of those programs, and I'm happy that you all are here interested in hearing about them. So send us your referrals. Thank you very much.
Appreciate it. Thank you, sir.